A big hand. Thank you very much.
We are sorry. Yeah, we are sorry to have disappointed you about not having intervened.
We are not disappointed.
Said, when not to intervene.
We are not disappointed. We have learnt to be wise. Okay. Thank you.
Well, thank you so much for giving us an opportunity. Thank you, sir. Thank you very much.
Can we go ahead with the lecture, please?
Dr. Roy.
Dr. Roy.
Sure.
Thank you, Chairman, sir. In the beginning, I want to express my gratitude to Dr. Srinivas Kumar for giving me a chance to summarize what my previous speakers have already established. So, what is very peculiar about primary angioplasty, or how it differs from a routine angioplasty? We will learn from an example, and we'll go with a case first. This is a 54-year-old gentleman who came with ongoing chest pain for last 1.5 hours, and ECG showed acute anterior wall MI. Blood pressure in the ER was 110/70, pulse was 92 per minute, and O2 saturation in the room air was 94%. And this is the picture in the cath lab, and it is a very usual picture. And when we saw the hemodynamics, the BP has already gone down. There was a bit of bradycardia. So we thought of putting a wire in and do thrombosuction. This is a thrombosuction catheter. And after the thrombosuction, the flow was established, though the flow was a little bit slow. But look at the blood pressure and the ECG. This is a routine phenomenon, and there are some microembolization would have taken place, and the gentleman required a little bit of catecholamines, and then we did thrombosuction again, and there was a perfusion, but the BP was creeping up. We put a stent there, and this is the final result. This is the final result. So, but the question comes, how do you describe a primary angioplasty in one word? This is basically a procedure which needs a lot of thrombotic, which is done in a thrombotic milieu and needs a lot of pharmacological support with mechanical answer to a lesion, and which is sensitive to time. So it has got three components. Number one, a time-sensitive procedure, a mechanical procedure, and some pharmacological support. So first is time. We know a lot of things about dot to balloon time, and we have seen that dot to balloon time is directly proportional to the mortality, but it has the dot to balloon time has got no reference to total ischemic time. Is total ischemic time is important? There is no answer to this right now. And probably all the studies which were done before to establish dot to balloon time in the earlier period is probably done on low risk patients and or patients who came late. That's why dot to balloon time was important. There was no reference to total ischemic time. Now the total ischemic time has got some bearing on the infarct size. And Tarantine in 2005 is established that with MRI studies it is found if the total ischemic time is long, keeping the dot to balloon time constant, it is found that the infarct size increases. We have done a small study of 50 patients in our lab, and it was found that if the dot to balloon time is intact, but still, if the total ischemic time increases, there is a 0.63% reduction of the predicted LV ejection fraction for each hour of increment of ischemic time if we go by the serial echocardiographic study. So, total ischemic time, if we are moving from the hospital setup to the community setup, and if you want to reduce the total ischemic time, you need to go to a larger, socio-economic perspective to reduce the total ischemic time, and not only, giving more attention to the hospital setting, but giving more importance to the community itself. Then came the pharmacological support, and you have already seen this slide, Horizon MI, where bivalirudin was increased, bivalirudin was used in place of heparin and GP2B3A receptor blockers, and it was found, everybody knows that bivalirudin did well, and that benefit was accrued, that benefit was persistent for the next 3 years. But if you look at the small increase in stent thrombosis in the initial period of first 30 days of bivalirudin and GP2B3A heparin comparison, you will find that there is a slightly increased trend for stent thrombosis. And there GP2B3A receptor blockers were used in intravenous form. So is there any benefit of putting GP2B3A receptor blocker in another route? We are not going into the details, but we saw that yes, GP2B3A receptor blockers, when they are used intracoronary versus intravenous, it was found the local administration of GP2B3A receptor blocker somehow could break the platelet bridges, thereby it can reduce the thrombus more, and it was found in Cicero study. That was that was an enzymatic infarct size estimation, and it was found with intracoronary abciximab, the enzymatic infarct size was reduced much more than when it was given intravenous. So we are also using eptifibatide intravenously, intracoronary, and it was seen in the smaller studies that intracoronary eptifibatide is much more effective than intravenous eptifibatide. Then came the thrombosuction, and if we combine together, the clinical rationale was to reduce the thrombus load, and it was found that if you can reduce the microembolization from the thrombus, which could clog the microvasculature, the LV function improvement is more and the mortality is more. This slide has been shown previously. I am not going into the details of these slides. And this embolization, it is found that in most of the cases the emboli is very small, but in many of our cases we could find such type of huge emboli which has been aspirated by a thrombosuction catheter. The recent trials could show that there is some benefit. Some trials showed benefit with thrombosuction catheters, and some trials still could not find benefit. But in TAPAS trial, FIDE trial, and EXPIRA AMI trial, they could show that with thrombosuction there is definitely a mortality benefit, and definitely there is an increase in blush grade after the thrombolysis, after the primary PCI. And this is a TAPAS trial. After 1 year, you would find that there is, if you compare the conventional PCI with and PCI after thrombus aspiration, the mortality of thrombus aspiration is much lower than conventional PCI. And EXPIRA trial also could show a significant decrease in mortality as well as increase in myocardial blush grade if you do a thrombosuction in before doing primary PCI. So the recent meta-analysis of about the thrombosuction is that the patients with AMI treated with PCI, the use of adjunctive manual thrombectomy devices is associated with better epicardial and myocardial perfusion, less distal embolization, and significant reduction in 30-day mortality. Thus, adjunctive manual thrombectomy devices, if not anatomically contraindicated, should be routinely used amongst STEMI patients undergoing primary angioplasty. So, we have done a few studies of thrombosuction with export catheter, and it was published in Indian Heart Journal. And this is a 23-year-old boy. This man came with acute anterior infarct, and this is the first picture. And we did a thrombosuction. We put a wire and did thrombosuction in the LAD. This is a thrombosuction in the LAD. As because it's a very austere LAD situation, we went with a wire in the circumflex and did the thrombosuction in the circumflex also. And after the thrombosuction, see, this is the result. So we did not do anything. We kept the patient as such, and we did a follow-up after 1 year, and see the follow-up. This is the follow-up angiogram. This is a follow-up angiogram. And so there was a very soft plaque perhaps, and after thrombosuction, and the flow was established, and we could do away with the thrombosuctions only, without any stent and without any balloon. So my question comes, and whether we should be using thrombosuction routinely, and whether we should be used intracoronary abciximab or intracoronary GP2B3A receptor blocker with bivalirudin to top up, so that the initial stent thrombosis care is reduced. And this is an infused MI study, and you have already seen that study before. You know, my previous speaker has shown that. But there is only one small thing about clearway catheter. We usually reproduce a clearway catheter in our lab by, piercing the balloon with a needle for small holes and putting the abciximab inside the, in deflator and just inflate it in the nominal pressure, so that it does the clearway catheter job when you do a primary PCI. And if you could put the balloon in the coronary artery and put the abciximab locally, I think it gives a very good result. And this infused MI also showed that putting abciximab and no abciximab, there is a significant mortality, infarct size reduction. Significant infarct size reduction with abciximab, but aspiration did not help. So we need few more studies. As for example, the total study. This is a study which is ongoing, where they have compared manual aspiration and without aspiration, and also the test trial. Again, this is 5,000 patients. They have done the PCI without. It is an ongoing trial. They are doing PCI without thrombosuction and with thrombosuction. And after these results come out, we could be putting thrombosuction device as a class 1 indication. Now it is class 2A. It should be putting, probably the guidelines should put thrombosuction as a class 1 indication in primary PCI. Now we move to the technicalities of primary PCI, and it was found that already it was shown that in our country the radial angioplasties are being increased, but still there are all funeralists. In my opinion, if somebody is more confident about one axis, he should go by that. And if you compare the results at radial and femoral, there is not much different, as I think. And also, femoral could be done if you think that you can be more justified to do a femoral and justify the lesions more with a femoral axis. Next is the guide cath and guide wires. Try to remain with floppy wires in most of the times. And if you use a hydrophilic wear, it should be soft tip hydrophilic wear. Occasionally stiffer wears can be used, and you must be careful not to push hard to go into the epithelial space. The balloons and stents, thrombosuction catheter in our lab is a routine, and in most cases we do a direct stenting if all that is needed. And stent sizing, there is we size the stent according to the proximal diameter, because in thrombus containing situations there is a chance that you may undersize the stent. So you go with a stent which is according to the proximal diameter, and use stents which open at low pressure and having minimal balloon overhang, so that you should not go with a very high pressure deployment, and you can miss a distal dissection or proximal dissection. And also deploy the stent at a nominal pressure and post-dilate if it is necessary. Now, DES and BMS already has been settled, and it is found that DES do not produce any scare for stent thrombosis and all, but it can reduce restenosis. So it is as safe as BMS, but it can reduce restenosis. So where it is possible, we can use a DES, and particularly the newer generation of DES. The DAPT is not very essential after 3 to 6 months. So I think DES would be a good choice in most of the cases of this primary PCI. So this is an algorithm for primary PCI in our lab, that if we keep the door to balloon time between 70 plus minus 10, we have to reduce it a little more further. Now, if the TIMI flow is 0 to 1 in most of the patients, manual thrombectomy and IC-GPI, usually we give IC-GPI and do manual thrombectomy by export, and Thrombuster. The Thrombuster is a new catheter, and you can export, it's a very soft catheter, and it is very difficult sometimes to go beyond the lesion. The Thrombuster is more, user-friendly, and it can go, take the curves, and it can go a deep insertion. So Thrombuster can be a better choice than export. And if there is a TIMI 2 to 3, go for a direct stenting if feasible. And if it is still TIMI 0 to 1, go pre-dilatation and stenting. And again, if the initial, there is a TIMI to 2 to 3, we go direct stenting if possible, and then we put it, if that was, if the result is TIMI 0 to 1, we put again GP2B3A receptor blockers intracoronary, and after manual thrombectomy and put a stent. So this is the algorithm of primary angioplasty and how we do it. Thank you for patient hearing.
Okay, I want to just thank the entire panel and my co-moderator, Dr. Piljani. This concludes the morning session on ACS, and our next session on bifurcation disease will resume currently. Thank you.